Indu did her post-graduation in ophthalmology at Government Medical College, Kozhikode, after which she went on to do her fellowship in oculoplasty at Little Flower Eye Hospital, Angamali. Currently, she is consultant in orbit and oculoplasty at Comtrust Eye Hospital. She'll be talking today on how to tackle lid tears perfectly.
Thank you, Dr. Anju, for that introduction. So towards the last session of our IC, we'll be dealing with the lid tears. So how do we tackle in its perfection? So how to repair a lid tear? What are the aims of a repair or a lid tear repair? What we need to do is we need to restore the functional aspects. So once after the repair, there should be nil watering for the patient, nil ptosis for the patient, nil lag of thalamus, and of course the best possible cosmetic outcome. So how do we achieve this? So the answer is always, I feel, it's a meticulous primary lid repair. So when a case of lid tear comes, what all things do we need to analyze? So these are the points that we should be thinking, we should be taking into account when a lid tear comes. Whether it's a partial thickness or a full thickness lid tear, whether it's a margin involving or not. If it's a margin involving, you need to be a bit more careful and expertise is required. And always remember, when it's a case of lid tear which is medial to the puncta, always never forget to do a probing and explore if there is a canalicular involvement. And also explore if there is any levator involvement if the injury is like above the tarsal plate. Another point that we need to assess is the tissue loss. So oftenly, there may not be much of tissue loss in many of the cases. It is always a pseudo appearance which gives a tissue loss like appearance. Okay, so it could be due to the recoil of the tissues, or it could be due to the edema, or maybe perhaps it could be due to, it's always like solving a jigsaw puzzle. So if it is not properly aligned also, it can result in a lacuna. So when you have placed this almost well, there might not be any real tissue loss. So coming to our main topic of interest, which is a lid margin repair. The basic principle of a margin repair is that these are the two very important points. The sutures need to be equidistant as well as of equal depth. So this is how it goes. Basically, we are placing a vertical mattress suture, and this is how it goes. So it is also called as 3-3-1-1 rule, or otherwise called as far near rule. So we enter through the we enter at a point of 3 meibomian gland orifice, and then horizontally take it at equal depth, come out at point of 3, and then again at a point of 1 you enter again, horizontally move, and then come out at the point of 1. So here, this is a video showing a full thickness lid tear which is involving the margin in the upper lid. Anesthesia is given, and here what I am doing is, because the tarsus is not much exposed, I am cutting a bit of the orbicularis, and I am taking the partial tarsal sutures at first. It is almost ideal to do the lid margin suture at first rather than the tarsus. So here, it has always to be a partial thickness one, otherwise it will rub on the cornea. Now on the margin you can see that I'm taking the suture, I'm showing the gray line at first, and sutures are to be placed at the gray line. So here at the point of 3, always ask your assistant so that you have to retract the upper lid so that you have a very good visualization. And the suture which is used for the tarsal plate, it's 6-0 vicryl, and for the skin lid margin it is always 6-0 mer silk. So once you're suturing it and tightening it, always see that you're doing in a horizontal way as you see in the video, horizontal way, so that you minimize the rub on the cornea. Again, ask the assistant, you should have a very good assistant to do that, to retract the lid. And the point of how much to tighten is a very important thing. So what you need to do is not just a very superficial approximation, is not just the end point. What you need to do is just a heap up position is required of the margins. Only then in the post-operative period it will flatten. So now the suture, simple sutures are taken on the posterior lamella. And similarly, a simple suture is also taken on the lash line. And finally, in the lash line suture, you can, in order to reduce the rubbing of the suture on the cornea, you can even bury the sutures, the lower two sutures, onto that. Now finally, closure of the orbicularis as well as the skin sutures. So this is how the patient looked in the post-op period. He is doing fine. Now if it is not well dealt, it can result in complications. Here you can see the lid margin notching. And also this is a very bad cicatrix which is causing the cicatricial ectropion. And even it can result in lag of thalamus. So now moving to the next one, that is a canalicular tear repair. The most common cases that would come to our casualties, and with this canalicular tear, it is often, in case of infants, it's the blouse hook injuries, but we see more cases among the siblings, which is due to cradle hook, and this is the most, this is the real culprit. So here is a video of the canalicular repair. Here you can see the floor of the canaliculus. This is the proximal cut end of the canaliculus. So the first and foremost thing that you need to do is a well dilatation of the puncture, so that this will help. So you're basically threading the canaliculus. So once, if it is not fully dilated, what happens is that you will end up in difficulties with insertion of the mini monoca or the unicanalicular stent. Now here you can see that this is the distal end, which is identified as the pearly white structure. Once it is seen, you need to confirm it by passing a probe, and you will get a hard stop. So now you are threading the canaliculus with the unicanalicular stent or the mini monoca. Always use a non-tooth instrument for the insertion. Now pull it out until you have that it is fully inserted. Now passing it through the distal end. Once it is the proper distal part of the canaliculus, it will go in fine, very smoothly. Now we are suturing the pericanalicular tissue and suturing of the skin. So the next step, but the most important step, is to suture the conjunctiva. This can be either done as the first step also, but always see that it is being done, otherwise the tissue may not hold and can even go in for necrosis. So this was the postoperative picture of the patient. You can see the canaliculus threaded with the mini monoca, and patient has nil watering. These are some of the cases of upper lid and the lower lid canalicular tear. And beware if the canaliculus is not, if the distal end of the canaliculus, it's not properly identified, and if it is not into the distal end, this can happen. The mini monoca, the distal end has come out through the skin here. So finally what we have to do is just take it out, remove the stent off. And this is the last slide. there are some certain conditions where you need not even suture, like in a very superficial wound, wherein especially if it's a kid, not able to, or we need to take in for a GA, you can avoid it by using a steri strips which are placed vertically 90 degree to the sutures. I mean, So with that, I would like to acknowledge my alma mater, Little Flower Hospital. Some of the photos I have taken when I was doing my fellowship, and Dr. Anju Chandran for the video. Thank you.
Thank you, Indu, for that lucid presentation. I believe this is one of the most basic skills, not just an oculoplastic surgeon, but an ophthalmologist should possess.